Hello and welcome to the Brain Matters podcast, brought to you by the Florey Institute, Australia's largest brain research centre. I'm your host, Dr. Shane Huntington. And together, we'll be exploring the fascinating world of brain health. We'll meet leading doctors and researchers and learn about the reality of a range of brain and mental health conditions from people with lived experience and their carers. In this episode, we'll be exploring epilepsy. 1 in 10 of us will have a seizure in our lifetime. There are many possible causes, but our understanding is still limited. The most significant cause we see is epilepsy, the most common chronic brain disease affecting people of all ages. We know that 70% of people with epilepsy could be seizure-free, yet many lead a life not knowing when their next seizure will even occur. In this episode, we'll explore the current and future options for seizure prediction and treatment and look to the future of complete seizure control. Joining me today to discuss this important topic is Professor Graham Jackson, Clinical Director of the Florey and Chief Investigator of the groundbreaking Australian Epilepsy Project. Graham's research into improving outcomes for people with epilepsy is recognised globally. Welcome, Graham.
Yeah, hi, thanks.
Also, we have Professor Aileen McGonigal, Clinical Director of the Epilepsy Unit at the Mater Hospital in Brisbane. Aileen is dedicated not only to preventing seizures in their patients, but also to addressing other common aspects of epilepsy, such as memory problems, depression, and anxiety. Welcome, Aileen.
Thank you.
Also from Brisbane, we have Max Luca, who lives an active life with a successful career as a personal trainer. Max also happens to have been living with epilepsy since he was a boy. Welcome, Max.
Thank you, Shane. Thank you very much.
Aileen, I'd like to start with you. Can you give us a broad description of what epilepsy actually is?
Sure. So epilepsy is actually one of the commonest chronic, meaning long-term neurological conditions. It's probably more common than people appreciate. And the way it's defined is a condition where people are prone to have recurrent epileptic seizures. So what's an epileptic seizure? That's actually quite varied range of symptoms that can manifest, which are caused by a brief, usually lasting seconds to minutes, temporary kind of disturbance of the brain rhythms. So the brain's kind of functioning by electrical activity. That's all the groups of neurons are kind of speaking to each other. And an epileptic seizure is a bit like an arrhythmia, similar to the sorts of electrical disturbance we can see in cardiac arrhythmias. So there's some kind of abnormal rhythm takes place in either one part of the brain or maybe both sides of the brain. And then that will develop and spread, and it disrupts the brain activity and stops the brain from functioning normally during that time. And depending on the type of discharge and which parts of the brain are involved, that will determine what happens to the person. So people might have seizures where they feel different. They may have impaired consciousness. Some people might have abnormal movements, might be at risk of falls and injury, or even have convulsions, which is the sort of maximum expression of an epileptic seizure. And people have very varying frequency of seizures. Some people have seizures a few times a month or a few times a year. Other people have very frequent seizures that might even be daily. And the type of the seizure, as I said, depends on the type of the discharge and which part of the brain. But it's usually quite similar for that person. It's usually the same brain networks that are involved in each seizure. And so there's a kind of recognisable pattern that we can characterise for each person.
Yeah, that was one of the things I wanted to explore with you. If I'm the sort of person who's getting one seizure a month, does that remain consistent from me, or is it the sort of thing that changes a lot during year to year in my life, or do I kind of have my version of epilepsy and I kind of stick with it?
Yeah, that's a good question. So it's tricky because one of the characteristics of epilepsy, which I think makes it very challenging to diagnose and treat as well, is that it's a very dynamic condition. So the brain is not an organ where the activity remains static. It's characterized by dynamic changes. And so even if, let's put aside the effects of medication for the time being, or other treatments. But if we just look at the course of epilepsy in a person's life, there might be changes related to age. So perhaps people who start having seizures in childhood as the brain develops and changes, then that might affect the seizure pattern. We notice in some patient groups, for example, women during the course of their life, they may see changes related to hormone fluctuations. Some women have epilepsy that changes during pregnancy, for example. So, and then there's all the impact of the different medications that we would use, because the mainstay of treatment, which I'm sure we'll come on to, is giving medications which have to be taken every day, which are, I mean, a bit like treating high blood pressure or something. These are preventative medications that need to be taken daily to try to help the brain to stabilize its activity and to avoid going into the epileptic discharge type activity. So sometimes when we start treatments or change treatments, we see a difference in seizures, and ideally we would see that the seizures stop with medication. That would be the ideal scenario. And in about 2/3 of people, that would be the case, that within trying the first 1 or 2 treatments, people become seizure-free, meaning that medication allows their brain rhythms to normalize sufficiently to prevent the expressions of seizures. But in about 1/3 of people with epilepsy, and these are the people I mostly see in our department in the Mater Hospital, which we call drug-resistant patients, in those people, although the medications may improve the seizure control, they might diminish the frequency of the seizures, so they might happen less often, or they may reduce the severity of the seizures, so they may have less, high-risk seizures. They may be less likely to fall, for example, or might not lose consciousness. And those are important gains for treating patients, but they typically don't become completely seizure-free. And then other treatments like surgery might also, of course, have impacts on epilepsy activity. So there are certainly lots of things will affect how epilepsy evolves for an individual over their lifespan.
Yeah, interesting. Thank you. Max, can you give us a bit of an idea of your experience with epilepsy? What you experience, how long you've had it. Talk us through that.
Yes, no worries. Well, you see, I'm 25 years old and I've been diagnosed since I was 18, but actually had epilepsy since I was about 12 or 13 years old. You see, I've had my focal and absent seizures since then. And you see, myself and my parents didn't really know what that was. You see, that is very typical nowadays because you see the public or most people don't really know that. You see, they hear or they know about epilepsy, but they think that is just falling to the ground, shaking, and possibly foaming at the mouth also, which is the tonic-clonic seizures. And that was happening fairly frequently. And then one day when I was about 17, nearly 18, my parents and I were on holiday in Thailand. And one night we were in a big room and I was asleep and I had a nocturnal seizure. My parents were still awake and they saw me shaking when I was asleep. So then they went, okay, we need to sort this out. Maybe this might be something different. And then when I was turning 18, came back to Australia and then got diagnosed with some EEG scans and some MRI scans. At the age of 18, we found out what it was.
Interesting. Now, Max, tell me, when you have the sort of more common seizures for you, which aren't that typical public view of on the ground shaking and so forth, what are you experiencing at that time?
Well, you see, I'm, for example, talking to you or talking to anybody or doing anything, I suppose, and I simply stop and I go completely, typically stable, I suppose, not completely unstable, but blank in the face, and my right arm usually raises slowly and my left arm might play around with my shirt or so, and my face is completely blank, not talking, not moving, not doing anything at all for about roughly, it used to be about 5 minutes, but through the process and through these years of changing and upping my medication and things like that, it has changed. The length and the time has changed, but the seizure itself is still the same. For example, I look blank and I'm still breathing, still doing everything, and I usually go slightly unstable. So some people who don't know what it is or haven't seen it many times, they get a slightly worried. They make sure I'm stable. They hold me. But friends, close friends and family, they just look at me and make sure I'm okay, because I sort of wobble a little bit. Yeah, that's what that is.
Are you aware of it happening?
I'm aware of it coming,
Right.
but not aware while it is happening. And that is why it is an absence seizure, because I'm completely absent of it happening. And then post seizure, so after it happens, when I return conscious, I suppose, if you would say, I go, oh, okay, that's what just happened. I had a seizure. Okay. I may be in a different location, for example, not completely down the road, but maybe on the other side of the house or sitting on the couch or something like that. But yeah, I come back.
And Max, you mentioned that you have some sort of lead time to this happening. What sort of lead time are we talking about there? And do you do anything to make sure you're okay during that time? Like, do you have to prepare anyway?
It's typically, I'd say, 10 seconds, possibly. This has been, these years, this has been one of the hardest things to explain to people. Even Professor McGonigal there and my other neurologists and doctors in the past, the hardest thing to explain is roughly 10 seconds, I would say. And then, for example, if I'm cooking or myself bodybuilder at the gym, I might quickly put the knife down in the kitchen or quickly put the weights down, because I'm conscious of it coming along. So yeah, I'm very lucky that happens.
Does that mean you can drive a car and do things of that nature, or is that too high risk?
I have not driven since I was 16 years old when I got my learner's license in Queensland. Got my learner's license, and then my GP back then didn't know what it was. So he just suggested, hey, Max, I recommend let's stop driving for a small time until we figure this out. And I had my learner's license for 2 months. Haven't driven since then.
With the work with Aileen, who we're also talking to on this podcast as your clinician, what does that mean for you in terms of medication and so forth? There's many options, obviously, for epilepsy. What has that meant for you? What have been the changes? What are you currently doing?
Well, that has meant the world to me. You see, I know that things don't change straight away. Myself, with experiences around me, such as friends or family dealing with other medical issues, I know that things may not change straight away. And myself as a personal trainer, I know that things with body and things like that don't change straight away. And experiencing it myself with my epilepsy and the change of medication, suggesting, for example, simply just increasing one of them by milligrams or taking one out and replacing it with a different medication, not confirming, yes, this will work, but let's try this out, because in the past with some people, it has worked in some ways. I just go, yeah, okay, I'll listen to you, because I know how professional that Professor McGonigal and, of course, other neurologists, I know how professional they are. They have all the certificates and all their professions in them. So I listen to that. I just go, yeah, okay, we'll do that. That is fine. And I'm very open ears and just listening. I'm not worried.
In terms of your hopes for the future, is sort of cure on your horizon, or is your life at the moment so rich and full with the current scenario that it's less of a concern for you?
I wouldn't say a concern for me, but of course, just like anything, I suppose, of course, I wish to have no seizures. I wish to cure this in the future. But you see, I know that it's nothing. Well, I suppose I wouldn't say nothing fatal, because there is possibilities with certain things, but I'm completely okay with it. You see, people that are very close to me, they know that I have seizures, and when I do, they are truly careful, that they care for me, and double check on my emotions and everything. But for myself, it truly doesn't bother me at all. So going through this process of trying different medications and things, if it takes 20 years, that's okay. That's okay to me. If it doesn't change, or it doesn't, if I don't get cured, I suppose, if my seizures don't end, then that's just how it is, because I understand that.
Max, how much education do you need to do with the people around you? Because as you said, the standard public view of what epilepsy is only covers a portion of people who have the condition. Do you find yourself often educating family, friends, colleagues on just the diverse range of how epilepsy can present itself?
All the time, especially people that I freshly meet, for example. I explain my seizures, especially if they see one. For example, if I meet a mutual friend anyway, for example, if I meet them at an event, or for example, a friend's birthday, and then they see one of my absent seizures or focal seizures, for example, then they, in no disrespectful way, but they just go, what the heck is this? And then they ask the mutual friend, hey, what is Max doing? Then he slightly explains it, or my friend, whoever it is, slightly explains it. And then when I come back, they ask, are you okay? For example, and then I explain it. It's okay. It's epilepsy. Myself, I don't do the usual thing most people know about of falling to the floor, shaking, etc., etc. So I explain that there are so many different seizures. And in no disrespect, a typical thing that I say to people is it is similar to cancer. There is so many different versions of it. That's how I say it.
And Max, how often do you have the seizures? Like what's a week look like for you?
Random. I track them. I have my diary, my seizure diary. Professor McGonagall knows herself. You see, whenever I see her, I show her my seizure diary. But they're very random. I don't know when, or I don't know where. I don't know how I'm going to have them. They often come in, I suppose, chunks is a simple way to say it, or groups. For example, maybe 3 days in a row, one per day, or maybe 2 in a day, and then 1, and then the next day 2 in a day, and then 2 weeks with nothing. For example, different ways. Whereas previously, as medication has changed, it's just changed. The longest time I have had with no seizures was, I believe, what is it now, 2025? I believe in 2022, I had 2.5 months seizure-free. That is the longest time I have had seizure-free. Yeah. But now, with this change of medication, they are very random.
Graham, in terms of the cause of epilepsy, I mean, what do we know? How much is genetic, environmental, behavioural? What components go into that scenario for epilepsy?
Epilepsy is a symptom of something wrong in the brain. We heard Max say about he uses example of many types of cancer. I've often said there's many types of sickness. You can say I'm sick. That could mean anything. And so if something goes wrong in the brain, it has 2 ways of expressing itself. It either stops working or it has a coordinated activity like a seizure. Anything that goes wrong in the brain can cause that. So you can have imposed injuries, you can have tumours, you can have birthmarks in the brain, or you can have a genetic background that just makes you more susceptible, or a combination of both. You can have prolonged febrile convulsions in childhood, which can damage things. So it's a whole area of whatever's wrong with the brain. You have to find it out. The special thing about epilepsy is that it's paroxysmal, so it's not there all the time. Something's working, like you can talk, and then you have a seizure, as Max has said, you can't talk, you're absent. And then after it's over, you can talk again. So something has seized a normal network in the brain and stopped it working. And so there's two things. There's the symptoms that engage these networks that were previously working, and there's the thing that drives that process, and that's what we try and work out.
Yeah, interesting. And when you have a person with epilepsy, are you able to track that cause in any way? So, I mean, I suppose in some cases it may have been where an injury is really obvious, but are there any genetic markers or anything that you can see that say, okay, we can see this particular scenario genetically, and that's probably the reason why there is a problem with the brain?
Yeah, and of course that depends on how much resources you can throw at what point of time in the patient's journey. In our unit, which is what's called a comprehensive epilepsy program, this is one of the major teaching hospitals in Melbourne. We assess over 100 patients a year in that program, and we maybe operate on 20 or so patients. But they're the ones that get the genetic analysis. We monitor them over a week in hospital. We get cognitive assessment. We get psychiatric assessment, and then you can put it all together. Very typically, when we start the journey, you have your first seizure. Usually it's a diagnosis and try a medication with some very simple investigations. So that's what we're trying to change, because by the time you get to the comprehensive epilepsy program, our average for assessing those patients for surgery is 22 years after they started having seizures.
Right.
So, the program I lead is trying to bring that down to right at the beginning so that you don't go through 22 years of drug-resistant epilepsy before you get that answer.
Yeah. So we heard from Max, of course, that it was quite a while before he was diagnosed with epilepsy. So when you say 22 years, is that from diagnosis or from the first sort of seizure you can track back in time?
Yeah, that's from the first seizure we can track back in time, yes.
Yeah. And do you see a change in the pattern of epilepsy during that period that is in any way dangerous or problematic? So if I don't get the treatment I need, does my epilepsy get worse as a result of it not being treated, or is that just sort of age progression? Can you tell?
Yeah, that's a controversial point, and there's data on both sides of that equation. Some people have many seizures and don't seem to be affected. Others seem to be a bit more vulnerable. And after they have seizures, they have a decline in performance. So it probably depends on your genetic background, the severity of the seizures, which network the seizures are in, and so on. So it has been said that seizures begat seizures because the brain gets used to being able to engage those networks. So the general feeling is it's probably better not to have lots of seizures.
Right. Yeah, fair enough. Aileen, with regards to the sort of medication treatment that is available, my brain immediately wants to tell me that, lighter versions or less significant versions of epilepsy, I suppose you could say, I'm not sure what the right language is there, would be more likely treated with medications than the really, severe versions. Is that the case, or is it more just person by person? Like, is that medication success related to the severity of the seizures and so forth, or is it just more varied?
I think it's difficult because it's so individual, the way different people will respond to any particular medication. And often, as we were saying, these patients with drug-resistant epilepsy, the types who are assessed in Professor Jackson's unit or in our unit who undergo monitoring and so on, they often find themselves on combinations of 2, 3, 4, even 5 medications every day just to try to get the best control that we can of seizures. So even sometimes, though, someone with fairly severe epilepsy who would be drug-resistant by the definition of having not become seizure-free after the first 2 medications are tried, sometimes we still have positive surprises where we'll try another medication they've never had before, or perhaps there's a new medication comes on the market because, of course, there's lots and lots of active research in pharmacology of epilepsy, and we're lucky to have new options that are appearing all the time, which is a positive thing. So sometimes we'll have a positive outcome by trying a new medication that a patient's never tried before, where we actually do get seizure control for the first time. So I think that's also a good reminder that people with drug-resistant epilepsy, meaning people with epilepsy where seizures are not well controlled, they should always be referred to a specialist team like Professor Jackson's or our one, or an equivalent elsewhere in the country, to look at all the kind of, I guess, to characterise as precisely as possible that person's epilepsy, to understand the cause, as you mentioned, doing detailed brain scans and EEGs, often inpatient video EEG monitoring over a week is indicated, as Graham said, and then trying to fine-tune the treatment options, either trying different doses of medications, changing medications, or even considering whether the patient might be a candidate for surgical procedures.
Aileen, if I was a patient coming in and seeing you, I think one of the first things I'd want to know is, are these medications going to affect the way I think day to day when I'm not having seizures? What do the typical medications do to the brain? Like, how do they work, and does that change my day to day? Like, are there side effects?
Yeah, this is a common question, common concern. Now, because all of these molecules work on the nervous system, so they're trying to stabilise these brain rhythms, like we said, by different actions on different neurotransmitters in the brain, which underlie how excitable the brain rhythms can be. So because they're working on the nervous system, they most often have side effects that can impact the nervous system function. So tiredness or difficulties in concentrating are reported quite commonly by people who take them. Other side effects that we always watch out for would be impact on mental health in terms of worsening of anxiety or depression, which are actually very common in people with epilepsy, more common than in the general population or even in other long-term medical conditions. So these are things that we look out for. There can also be impacts on parts of the body where the medication is being metabolized. So, for example, we often do a blood test to check liver function when people are taking some specific medications. And I should mention actually on that of course we're also very cautious in women of childbearing age where there may be a pregnancy, either planned or unplanned. So because these medications are very good for treating epilepsy, but they're not good for a developing fetus, we have to be very careful in advising women who may become pregnant about, the kind of the risk-benefit profile of the medication. So that's a big part of the work of specialist teams as well. But just coming back to the question of side effects more generally, so I think for every individual patient, so as we said, this is always, each person is different. So we're always trying to make decisions as clinicians based on that particular patient, which is difficult because the scientific data that we have tends to come from large groups. So we're always trying to kind of extrapolate that and apply it to this person in front of us in the clinic. And so usually I say to patients that although people often are worried about tiredness or memory loss, they often talk about in terms of the medication side effects. In fact, if they've got ongoing epileptic seizures and even small low-grade seizures they might not always be aware of, that also causes tiredness and memory problems, concentration. So I think we're trying to get the balance right between keeping the seizure activity under as good as control as we can achieve without overloading the potential side effects of medication. So we manage that just in a very practical way of seeing patients regularly in our clinics. I'm sure it's the same in Professor Jackson's team as well. And really just monitoring how the patient feels. That's the best judge of how someone is going with their medication, and we're always ready to reevaluate that if a particular medication combination doesn't seem to be suiting them.
Graham, sadly, as we look around many countries in the world, we know that the healthcare system differentiates itself quite significantly by postcode, and we don't all necessarily have access to the same scenario. What is that like for epilepsy, and in particular, what are you doing with the Australian Epilepsy Project?
Well, Shane, I think you've fleshed out fairly well the journey for the patient. Has lots of dead ends, lots of try this, see how it works, try that. We've established that each person is an individual. When I see a patient who has their first seizure, say you had a seizure this afternoon, come see me, and you ask the question, am I going to have another seizure? The best predictive model is tossing a coin and seeing whether it's heads or tails, 50-50. Right. And if you ask which medication's best, that's not going to give me least side effects, I don't know, try this and see, and we'll try another one afterwards. These are big problems. And the other thing is, other big problem I would frame this with is that when you get to a real expert like Aileen, you will get great treatment, but that's only if you get to her. And most patients rattle around with GP, particularly if you're in rural or regional. There's always this feeling that if only I saw the right specialist, I would be treated and I would not have seizures. So let's keep trying. So the patient journey is very complex. So we are in a new era. Our healthcare system was designed a long time ago, even before the internet, maybe. In fact, in Victoria, for example, there's 30 independent healthcare centres called hospitals, all of which set up their epilepsy programs separately. So we're in the era of data. We're in a digital era. We're in an era where we can access almost anyone via tele mechanisms. And although we can't expand expertise, we can expand data. And the data I'm talking about is advanced imaging, cognitive testing, genetic testing, and then if we should be able to put that in an AI model and start replicating at least some standard of care that is universal, that is population-based, that's accessible, and also reassuring in the sense that I've been part of this project, I know I've got the best treatment.
Right.
So confidence in the fact that someone's paid attention to your individual needs is important.
Which it's interesting you say that because if you're a cancer patient, for example, in Australia now, there are many comprehensive cancer centres where I believe, with family members, when they go there, they do feel this. They feel as though that cohesion of care is happening. To a degree, not perfect, but to a degree.
And to some extent, we've all got these comprehensive epilepsy centres, but they tend to be small and not of the scale, and the problem's quite large, as we've heard. The other thing is, there's, from my point of view, I've done research in looking at modelling the brain with advanced imaging, both its function, its structure, its connections, its wiring, and to get that to be used routinely in clinical practice is a very hard change from research into clinical care because it requires expertise and it requires support and it requires a new way of thinking. So, for example, I remember very clearly being at a lecture with one of my ex-students who was becoming a professor in Calabria, and he said, well, if only I could buy your package, and someone set it up like Siemens puts in a diffusion package and trains us, we'd use it all the time.
Right.
So you do have to have these commercial mechanisms. And the other thing is if you have this data, what we're trying to do now in the digital era is to create a digital twin of how your brain works.
Right.
And that should have predictive power of, drugs and which networks will be affected and so on.
So that a digital twin being a full simulation of how your brain works to some degree. Can we do that?
Yeah, yes, but the word "full" is the one that has the trickiness in it, and we are collecting data that is, in my opinion, capable of doing that.
Right.
So it should be able to predict mood disorders, depression, and all that sort of things. And then if you have the multimodal data of proper cognitive testing, which can be done in someone's home via telehealth, you have the attend and get the proper package of scanning, which we can analyse, and you have the genetic background plus the clinical history. That should be the starting point for where people like Aileen and I start treating a patient from, rather than the end point after 22 years of failure.
Interesting. And, how do you put that in place? Because as you say, you've got this scenario where there are many distributed individual centres. Everyone's an expert. Everyone feels like an expert. And as a patient coming into that setting, I have no measure. I mean, I might get a feel after a while if I'm not getting anywhere, but I really have no measure of what expertise looks like. So how would that work? Like when you have this system, is it getting those individual centres to access what you're putting together or override some of the decision making? What does that look like in a health setting?
No, it's not overriding, it's assisting. So that's what we're trying to do in the Australian Epilepsy Project. So I've set the project up. Aileen's a user of the program, so she can probably tell you what it's like to have that help up front. But we've set up sites in each state and everything else is done via communication. So the information from the patient, the records, we log in on Zoom and do the cognitive testing. We've developed software to do that. Right. And then we're putting it together in a package where we can pass it back to the decision-making neurologists to assist them in their decisions. So it requires one touch point of physical locality where someone has to come into the machine to actually have the scans. Yep. But that's something you can do at population scale. You can do it for rural and regional. You get out of the postcode medicine. And in fact, I think our healthcare system is going to have to go this way. This is the future of healthcare in many areas. I think we're early pioneers, I hope. It's a question always of who's going to fund it. We're fortunate to have initial funding from the Medical Research Future Foundation Frontiers program. We're pioneering a way forward, and that's exciting.
Aileen, when you interact with the system, I mean, even when we talk about epilepsy, it sounds like we're talking about one thing, but it's such a varied set of conditions. And my experience with expert clinicians is they tend to be really great at a couple or a few, they really focus. But this must give you access to other, neurologists similar to yourself, but who have different focal areas in terms of even just within epilepsy itself. Is that right?
Oh yeah, completely. So do you mean with regards to the Australian Epilepsy Project?
Yeah.
What that can bring? Yeah. No, that's been very exciting. We're big fans of this project. It's just fantastic. And lots of our patients in Queensland have benefited from taking part already. So the way, just to give people a sense of how it works in practice, so when a patient with epilepsy is seen by a neurologist, anywhere around Queensland actually, although at the moment the focus has been most around the southeast part of Queensland, if they meet the particular criteria for different groups, and one of those is focal drug-resistant epilepsy, another group is newly diagnosed epilepsy, and then there's another category for people who have had a first seizure. As the treating neurologist, we can go online, connect to the portal, and then refer that patient to the Australian Epilepsy Project. And we at Master at our institute, we're lucky to have a good research team who provide support to organise the different contact with the patient, to have the patient receive information about the project, to sign consent, and then we can, book the different parts of the evaluation. As Graham was saying, there's a set of telehealth evaluations for cognition, which includes memory and language testing. There's also some testing of patients' mental health, filling out some questionnaires and so on. And then they physically need to travel to Brisbane for a high-resolution MRI scan. So this is a brain MRI like many patients with epilepsy will have already had, but it's a dedicated and kind of state-of-the-art evaluation, which is above and beyond anything that we can do in the hospital setting. So as part of that, there will be, for example, high-resolution images of certain parts of the brain, which we know are often involved in epilepsy. There will also be some testing during the MRI to actually look at the function of the brain, to look at language and memory functions. There's a functional MRI component, which isn't done routinely. And that brings very useful information because sometimes because of the epilepsy, the brain function has been reorganized. So it's very important to know about that. And then a genetics test as well, which is a home test that the patients have a swab and they take a mouth sample of saliva, and then that gets sent to the labs in Melbourne. And then the clinicians, after all these different tests have been completed, the clinical referring team receive a very comprehensive report with the results of all the different tests. And, we're really benefiting in Queensland from all of the expertise in Melbourne built up over decades in terms of the very advanced epilepsy research and clinical practice that they have there. So we have the scans reported by the Melbourne, Austin neuroradiology team, which is fantastic. And that's actually already Graham knows, we've quite a few patients where, the standard MRI scan, albeit of very good quality, performed in the usual conditions up in Queensland, has then proven to have some extra, subtle finding that's been detected through the AEP. And, that can make all the difference to how we're going to treat that patient. So already we're seeing the benefit of it. So the overall goal is to collect data, as Graham said, to, advance our understanding of all these different phenotypes of epilepsy and how we can manage them better as a community. But in the short term, we have really very rapid feedback on results. So it's very exciting to be part of that.
Yeah, excellent. Graham, I want to ask you a somewhat delicate question about the brain. If I'm in one of these groups where the medication's not working and surgery becomes an option, I personally would feel as though taking sections of my brain out or changing sections of my brain would be concerning. How do you know that that's okay? Like, is it only viable in certain areas of the brain? Like, how does that play out, the surgical pathway?
This is where you need to have trust and confidence and a relationship. When we were setting up the Australian Epilepsy Project, we featured a 16-year-old girl who was having nightly seizures of the shaking sort and very violent. And we found a little area with very advanced imaging right in the middle of her language area. And we did a very, very small operation just to take this tiny area out, which is not normally you take a bigger chunk, which would have affected her language. I mean, she's been 7 or 8 years seizure-free now. She's a teacher. She's getting married. She's driving. She's forgotten she ever had epilepsy. She only had it for 18 months, but she would have had it for her life without that small surgery. The general principle is if you've got a bad bit of brain that's not working properly, taking it out won't hurt it. If you've got a normal bit of brain, you take it out, you're probably going to miss it. There is a lot of redundancy in the brain, so there's a lot of reserve and your brain can reorganise. And I think epilepsy surgery has been around a long time, and I think these advanced teams of the sort Eileen runs and I'm part of have got a lot of experience on what you can do and what you can't do. Yeah, look, it's a lot of communication, it's a lot of support, it's a lot of confidence, and you get confidence from having an expert team with good data.
Yeah. You mentioned that great success story of one of the patients there. Does it come back in another part of the brain, or is that uncommon?
Yes, seizures can come back many, many years after successful surgery. You can have people 20 years after successful surgery start having seizures again. Whether that's because of the scar we created or the blood from the time or the underlying tendency to have seizures, we don't know. But mostly if you have a successful operation, you remain seizure-free.
Yep.
And the difference in the girl I spoke about is that she had a surgery 18 months into her disease and got to live her 20s and now into her 30s completely normally. Whereas if she hadn't had that surgery, she would be now starting to be assessed. She wouldn't have all those life things. So the health economic impact for doing this properly is huge.
Yeah, getting to it early. One question I like to ask everyone at the end of these podcasts, and Aileen, I'll start with you. If you suddenly had a large injection of funds, what would you do first?
I think I would create more specialist epilepsy monitoring units in Queensland. I mean, this is just based in Queensland. I think the whole of Australia and probably most world countries could benefit from more. I think, as was mentioned at the start, we just don't have enough in terms of specialist expertise. I'm very aware of that actually coming to Queensland from Europe. And one of the challenges is just the huge distances where patients can live actually very remotely and never actually get to see a specialist team as they should do. So yeah, I think there's definitely a lack of just the proper expertise and this hospital setting with monitoring units and advanced imaging and so on to be able to assess people, because undoubtedly there are people out there who, if we could evaluate them in a timely way and either adapt medications or treatment or propose a surgical option, like the person that Graham just mentioned, we could, that has a life-changing effect, especially if that occurs early in the epilepsy history. So that I see that as a huge gap at the moment.
Aileen, thanks so much for joining us today.
Thank you.
Graham, same question for you. The truck rolls up with the injection of a large amount of funding. What's next?
Well, the truck's already rolled up with a large amount of funding for the Australian Epilepsy Project. That was $30 million to start on this vision. Mm-hmm. I think the biggest truck we need next is how to sustain that and how to make it the standard model, because I think the diagnostics has to be at population scale and accessible by whole population and data-driven. But the next bit you would do is complete the circle to the therapeutic sites that Aileen's talking about, where you've got the expertise to do surgery, you've got technology that makes that surgery more accurate and precise. So the the interventional side needs to change from diagnostics to when we find these people through a project like we're talking about, you can do something about it and you can do the best thing that's possible about it.
Yeah. Thanks so much for being on the podcast today.
Thanks.
And Max, really appreciate your time.
Thank you very much, Jane.
You've been listening to the Brain Matters podcast, brought to you by the Florey Institute of Neuroscience and Mental Health. Join us for our next episode on brain health, and if you have a particular topic you would like us to cover in the future, please drop us a comment or send a message via the email in the show notes. I'm Dr. Shane Huntington. Thank you for listening.